right now. I'll just start the presentation in a few minutes. I'll just open it. I hope that is visible.
Yes, ma'am, you are visible.
So today we'll be covering why there is a need of palliative care for patients with non-malignant illnesses and what all patients would benefit from palliative care, and how to identify such patients. Many a times we hear the questions like, how do we know that this patient is to be referred for palliative care? What are the criteria for referral? Or how do we recognize that it is what kind of patients are needed to be referred to palliative care? There are a lot of illnesses which comes under palliative care, especially in the advanced stages, but we'll be touching upon COPD, heart failure, dementia, end-stage kidney disease, and some of them are major illnesses that we commonly see in the country. So we'll start with the case scenario of Mr. George. Mr. George is an 81 years old retired teacher. He lives with his wife, Susan, and he was diagnosed with dementia around 5 years back, and now he is deteriorating. And George is dependent for all aspects of his care, like he has bowel and bladder incontinence, and he has difficulty in communicating. So he's completely dependent on his wife and the caregiver for all his activities. He's able to walk only 2 to 3 steps. And in the last 1 year, this patient George is seen by a general physician, neurologist, and a cardiologist. In last 1 year, he had 3 admissions to hospital for pneumonia, and the last admission lasted for 4 weeks. And after each episode, he did not recover back to the point where he was at before. And in the last admission, he died on a ventilator. I understand that this might be a very common scenario in many of the settings. I personally have seen this a lot among our relatives or very few friends, families also. And we need to think about how could we help Mr. George in terms of controlling his symptoms, in terms of improving quality of his life, how he should have died, whether that was an appropriate death. We are not people who can judge whether it was appropriate or inappropriate, but seeing George deteriorating for last 5 years on and off hospital and clearly deteriorating illness trajectory, what could have been the end of life care that George might have received, and how to support Miss Susan after George passed away. So these are the things that I think broadly we will cover upon. We all know that we don't need any review on the definition of palliative care by WHO. We all know this, and we have been hearing this again and again from many faculty. And in 2018, IHPC have redefined palliative care, and this has been accepted by consensus. And this specialty will now cater to patients and caregivers with serious life-limiting or serious health-related suffering. That's devised by IHPC in 2018, and which is the most commonly used criteria to see whether the patient fits in palliative care or not. And you can see n number of illnesses being listed under non-cancer palliative care illness. It starts from atherosclerosis. I think almost every other chronic illness comes under this list. And this is another picture, sorry, of a serious health rate. Sorry, I think it's something is happening. It's changing on its own. Sorry. I don't know, one slide it's just changing on its own. which I wanted to show. So that was basically showing the increase in the incidence of non-communicable disease trend from 2016 to 2060. I'll be sharing this PPT so you can refer that for further use. And this figure, we can see the distribution of major cause of death in the world and how the change has happened in last 20 years. We can see that the death due to communicable disease, that is the red area. Red area indicates the death due to communicable disease. It is gradually decreasing in size towards 2017, right? Initially, in 1990s, it was wider and it has become narrower when it reached 2017. But we can see that there is an increase in the incidence of non-communicable diseases by 2017. So this is a situation in the world. But what happens when it comes to India? In India, also we have a decrease in the red color, the communicable diseases, maternal, neonatal, and nutritional diseases. But we know that there, we can see that in this graph, the blue color, there is a steady increase in the early 2000s till 2017, a steady increase in the incidence of incidence of non-communicable disease as a major cause of death in our country. So this signifies like how important it is to expand your palliative care services to illnesses other than cancer. So for example, if I take the story which happened in Pali in India, when we started in 18 years back, most of the patients were cancer patients. But now if you take the statistics, around 60 to 65% of patients have non-cancer illness, only the remaining have cancer. So the trajectory of the incidence of non-cancer illness have increased steadily, even in our setting also. And we know that the disease burden in terms of non-cancer illnesses, the major chunk goes to the cardiovascular and chronic respiratory illnesses, followed by cancer. And very recently, especially in Kerala, Kerala is the diabetic capital of the country. So diabetes is in a steady growth, especially in Kerala, but also in the other parts of the country. And non-communicable disease has become a leading cause of deaths in rural India. We know that around 32% of all deaths could be due to NCDs. I know that all the statistics will be familiar to many of you because you are all in a teaching institution. But just to understand why we talk about this, this needs kind of everyone in the same page. And this is a disease burden in 2017. This is the data from ICMR 2017 regarding the state level disease burden. That is 48 to 75% of current disease burden is NCD. And that is also highest in Kerala, Goa, and Tamil Nadu. And many other states like Bihar, Jharkhand, UP, and Rajasthan have lower numbers. There is another study. This is a retrospective cohort study, which is done on community hospital and palliative care provision in UK in 2016. And these are the results, which is very interesting. They say that around 4,000 plus patients were, 4,000 plus patients were included in the analysis. Around 700 had non-cancer diagnosis. And they were given palliative care around 16 days before death. And this is a country, UK is a country where palliative care was evolved years back. They are the pioneers in the country in terms of palliative care. Again, in that country also, the people are being referred, patients with non-cancer illnesses are being referred very, very late to palliative care. They got palliative care only in the last hardly 2 weeks of their before their death. So there is a quiz for everyone. You can type it in the chat, option A, B, C, or D, which is the most common symptom cluster of advanced cancer as well as AIDS, heart disease, COPD, and renal disease. What are the most common symptom cluster that we see in all these illnesses? So there are 4 options. You can choose any of them. What is the most commonly seen symptom cluster? I'll wait for the responses. I can see A, option D, many A's and a few D's. So yeah, thank you for the response. Again, I can see A and D. So A is the most commonly seen. I totally agree that depression, anxiety, and anorexia may also uh, uh, a very common cause. But this study was done, which I referred to, is it 2006. There are not much studies actually in the recent, especially in the country. These are all mostly from other countries. But they say that the pain, breathlessness, and fatigue were found among more than 50% of the patients for all 5 diseases. So, why do we need to refer patients with non-cancer diagnosis for palliative care? These are the questions that we often hear when we start talking about palliative care in non-cancer illness. Most often they ask, why do they need palliative care? We understand cancer needs palliative care because everyone can picturize cancer as a dreadful disease, or everyone can picturize when someone is diagnosed with cancer, they go through suffering. It's easy for people to relate to. But when you talk about non-cancer illness and palliative care, many a times they ask, why do they need palliative care after all? And they say, okay, there are so many NCD clinics in the country. Why do they need a separate, why do they end up in palliative care after all? So that's a very often asked question. This is a very early study in 2006. And they say that symptoms that we see in many of the non-cancer illnesses are very similar to advanced cancer. So if you take HIV, you can see that pain, breathlessness, and fatigue is very common, which is also very common in cancer. So any disease you take, most of these diseases have common symptom cluster as that of an advanced cancer. So this is the paper shows the findings that you can see how prevalent the symptoms are. It is not just in cancer. Dyspnea, obviously COPD at the end stage will have around 90 to 95% chances of dyspnea. And you can see the second line, there is pain. You can see how important it is to have pain control when patients with advanced HIV. Again, fatigue is very commonly seen in heart failure, which is kind of comparable to cancer, right? 32 to 90 in cancer and 69 to 82% in heart failure. And you can see how in CKD and in cancer, CKD patients go through more anxiety than in cancer patients. So many times, personally, I feel even in the community, when someone is diagnosed with cancer, they get a lot of empathy and compassion. They understand, okay, this person might be going through a lot. But when it comes to CKD, people are unaware. Okay, this patient can, or CKD or any other illness, it can be COPD or heart failure. Even the medical doctors, they do not understand what kind of suffering they are going through. Many times communicating the bad news may not happen in non-cancer illness because of the pattern of disease trajectory. We know that it is not really as easily as predictable. Sometimes there will be ups and downs, and even after hospitalization, they may not go back to their normal. So it's very difficult to predict the illness trajectory or to have the conversation. So many a times what happens is that we do not tell them about the irreversible pattern of their illness. To take an example of COPD, we had a session on for respiratory physicians. We did a course, the whole series for respiratory physicians on palliative care. So many of them agree that it is easy for them to talk about the diagnosis of cancer and its prognosis. But when it comes to ILD or COPD, it is very difficult to communicate with the patient and the family about the irreversibility, because they think that this is breathlessness. I take few inhalers and I'll be back to normal. It's very difficult for the respiratory physicians to recognize when should they start communicating that this is irreversible, or this is a bad, it's a time where your illness trajectory is going down. So these are the concerns that they were sharing. And in COPD, they say that the patients with COPD have, in terms of breathlessness, they have much worse, they go through much worse than the lung cancer, actually, in terms of daily physical, emotional, and social functioning. But we never take it that way, right? When you hear lung cancer, we feel that, okay, there is a lot of breathlessness, pain, and a bad prognosis. But when it comes to COPD, we generally tend to see it as a chronic illness, and we may not be able to picturize it as a very an illness where the patient is going through a lot of suffering physically and emotionally. And non-malignant disease patients were troubled by shortness of breath about 94%. And none of these patients got specialist palliative care services. Very rarely. I understand that there are at least around 50 participants in this. How many of you have referred or have got referral for patients with COPD, especially for controlling their symptoms? Very, very rare, unless you sensitize your respiratory physicians about the importance of palliative care or in symptom control in COPD. Again, another study, the similar proportions in the two groups of patients wanted comfort-based care and did not want ventilation. And patients did not want ventilation. About 80% of them did not want ventilation, but more COPD patients received ventilation. That is 70% versus 20. So this is a very interesting study which is published in 2000. This is called Dying with Lung Cancer or COPD Disease Insights. So this is a very interesting paper where both of them go through very similar kind of symptoms, but what do they receive in terms of palliative or supportive care? If anyone is interested, please read this particular paper. And what can be done in terms of COPD? We know that sorry, I was waiting for the vehicle to pass. Yeah. So we know that the stepwise approach to the management of dyspnea. We'll be covering this in detail in another session for palliative care and respiratory illnesses. But it is very important to follow up regularly and reassess the symptom. And along with the disease modifying or the usual inhalers and other therapies, it is very important to incorporate non-pharmacological approaches also. It is not just about medicines, but also non-pharmacological interventions also. We'll be talking in detail, so that's why I'm not touching upon the management of dyspnea in patients with COPD. Again, we'll go to heart failure. So there is another question to you. What percentage of patients diagnosed with heart failure die within 5 years of first hospital admission? How many of them will die within 5 years of first admission? I can see 30s and 50s. Thank you so much for all the responses. I think I missed a few chat and yeah, about the interstitial lung disease. Yeah, thank you so much. So around 50% of them die within 5 years of hospital admission. And how many of them are being, I'm so sorry, I live very near to the medical college, so you can hear the ambulance every minute. I'm so sorry for the background noise. And so about around 50% of them die in 5 years of first hospital admission. But how many? So I am working with Pallium for last 10 years. Very rarely I have seen patients with cardiac heart failure being referred for palliative care by the treating physician. They do come at the end stage referred by someone else because they are in Kerala. They know that palliative care people will do something about symptom management, but otherwise directly referred by the physician for cardiac failure, I have not seen in last 10 years. They are not being referred. And this is the incidence of heart failure in UK. That is 1 in 1,000 population per year. And they say that the survival rates are worse than breast or prostate cancer. And that is in UK, where breast and prostate cancer has a better survival rate than in India. So there is that disparity there, I agree. And they say that half the patients, that is 50% of them, die within 5 years. And between 1/3 and 1/2 of the patient dies suddenly, irrespective of the stage. So there is a potential for sudden death creates a need for discussion because they need to be prepared that this. So how many of these patients know that they are going to die? Many of them think that this is a heart condition which is treatable and I'm back to normal, right? How many of them know that? So when you say you have cancer, then even if it is a curable cancer, people think that I'm going to die. But when you take a patient with heart failure, when they're diagnosed with heart failure, how many of them know that they can, 50% of them can die in 5 years? I think none of them. We generally don't discuss about the disease trajectory or the irreversibility in many patients at all. So this is a definition of New York Heart Association heart failure class and American Cardiology, College of Cardiology. I'm not going through that in detail because just to understand that the stage 4, when they at least when they become stage 3, there is a marked limitation in the physical activity. And in stage 4, unable to carry out any physical activity without discomfort. So I personally feel these are the times where they need at least referral to supportive care so that because here their physical activity is limited, they are unable to do things on their own. That will be the time where they need preparation. Their family members need preparation to go through what they are going to face. Yeah. So this is based on New York Heart Association. They say the appropriateness of drugs for systolic heart failure around LV of less than 40%. How appropriate it is to give these particular drugs. I'm not reading one by one, but we know that it is diuretics is one thing that is very commonly used, and you can see hospital admissions are something which needs to be decreased. Again, end-stage kidney disease. At least this is something which is coming up in the recent past, probably. There are certain hospitals where they have renal supportive palliative care, maybe because of the burden that it caused because of multiple dialysis or the financial burden, probably. This is something that there is some acceptance which needs palliative care, especially in ESRDs. So this is another question. Patients who benefit from palliative care in end-stage kidneys disease are. So A is those who choose or are advised not to embark on dialysis. So those who are not on dialysis, or those who are failing to thrive on dialysis, who experience worsening quality of life, or those who continue to have dialysis. Which kind of patients do you think needs palliative care? Yes, thank you for the response. Along with it, I am just reading a comment from Dr. Prakar. Very, very true. Is it so? Basically, he's asking, why do we need a separate referral to palliative care? Ideally, do you think that the physicians should incorporate these things into their practice? I completely agree that every physician, any specialty, starting from the primary health center, a primary treating physician, or to the specialist, everyone can have this palliative care approach. Everyone should understand the relevance of symptom control. Should be, so suppose any patient, like you mentioned in the chat, COPD, heart failure, end stage kidney disease, the moment they find that this is the prognosis is really bad, they should ideally focus their care shift of concept, shift of care from curative to symptom control. That is the ideal scenario where everyone should practice palliative care. And that is the very reason why we run these courses, where every one of you should be able to give this approach, provide symptom control in whichever patients you are seeing. You don't need to refer that to a specialist. So there are certain conditions which needs referral for specialist palliative care. But everyone should incorporate palliative care in their practice, especially when they are seeing serious health-related suffering. So I totally agree to that comment, and that is what we look for. So there are specialists like MD palliative medicine doctors in the country. So there are certain patients who need those reference, but by and large in our country like India, what people need is the generalist palliative care approach, where every one of you should be able to understand, okay, this patient is going through a last stage of illness or going through a stage where symptom management is more important than curing the illness. So you should be able to, you don't need to refer to us to do something. You don't need to have a specialist in place if everyone is sensitized and how sensitized about the concept of symptom management, reducing the serious health related suffering. Thank you for that comment. So end stage kidney disease, we've seen these are all of them come into the criteria for receiving palliative care. We know that how bad is their quality of life. They need frequent hospitalization. And we know that the prognosis is very, very comparable to cancer. And many symptoms, they'll have breathlessness, pain, confusion, anxiety, depression is very, very common in the last few days of life. And we know that how much money is being spent, how much energy, money, the caregiver distress is being spent for all these procedures, and waiting for the donor and not receiving a donor, continuing the dialysis, then continuing whether to continue it at home. All those infections and pain they go through is very, very difficult. And this is a retrospective observational study which is published in 2013. In this, they have compared the survival and palliative care involvement of two groups of patients over 70 years. So one group chose conservative management and the other group chose dialysis in advanced CKD. So this was a comparative study. And they found that patients over 80 years with a poor performance status, high comorbidity score survived longer. So when they chose the conservative management, people 80 years old, more than 80 years old and poor performance status, they lived longer when they chose the conservative management compared to the other group. So coming to dementia, we know that this is one diagnosis that we come across every now and then. Even we also get referrals for patients diagnosed with dementia. So which of the following is the most common symptom in advanced dementia? We are talking about advanced dementia. Which of the following is the most common symptom? I can see a few A's. Yes, confusion is the most common symptom in advanced dementia. They say 83% of patients will have confusion, followed by urinary incontinence and pain and other symptoms like low mood, constipation, and loss of appetite. And can you see, these were the symptoms that we are talking about in cancer also. The incontinence part, the pain, the constipation, anorexia. We deal with these symptoms in cancer patients, especially advanced cancer patients. So this is another functional assessment staging, not reading one by one, the stage from 1 to 7, depending on how much dependence they have in their daily activity, how much assistance they need in dressing, bathing, toileting, and other things. This is one of the most commonly used global measures. One is clinical dementia rating scale, that is a CDR scale, or the functional assessment. This is a fast scale. It's called functional assessment stage scale. And another one is global deterioration scale, that is GDS. This mainly measure based on the functioning and ability to perform their activities of daily living. So I'll just. So what are the palliative care interventions in dementia? What can we do for patients with dementia? First thing is definitely symptom control. And other thing that we don't talk about or don't do much in our country is advanced care planning. We don't, even though we talk about it, there are a lot of legal ambiguities in terms of advanced care planning that we have been discussing a little bit during the medical ethics session. In practice, we don't talk much about advanced care planning, but this is very, very important in dementia because we know that the confusion is the most common symptom, and at some stage they won't be able to take decisions on their own, or they won't be able to tell what do they want. So this comes in plays a major role in terms of dementia palliative care. And avoiding potentially burdensome treatments. We know that the patients will be on multiple drugs. So I had an experience in my own family where my own uncle was on multiple medications, and he suffered mostly from the side effects of medications than from dementia. So at some stage, the symptoms were too bad that I had to stop all the medications one by one, but tapering and stopping. Once everything was stopped, at least he was confused. He was still confused. He was unable to walk. He was bedridden. But at least the difficulties or side effects which he had from the medicines, the treatment was much better. So this is something because the caregiver keep telling you he's not sleeping, he's very restless, not recognizing this, he's not unable to walk. So all these keep coming again and again. So for that, we keep giving something or the other medications. That's what we do as a practice. So then they get into a big burden of getting treated for all these symptoms. So it's very important to avoid the burdensome treatments. Sorry. And referral. When we don't have the concept of hospice in our country, but at least we can take it as a palliative care referral, and how to support the caregiver. In dementia, caregivers go through the most, not just in dementia, I think in any neurological illness, it's the difficult part for the caregivers to go through all these distress and how to manage these symptoms along with managing with their own emotions and burdens to take care of these patients. So so we need to extend our support to the caregivers also. There are certain places where they give respite care, where they will admit the patient for a week or two so that the caregivers can be at peace, can do some of their own time. They can do their health checkups, or they can have their own time for 1 or 2 weeks. So the hospice will take care of the patient. So that is something called respite care. Not very common in the country, but there are certain places where they admit patients for respite care. And other than dementia, we know that ALS or motor neuron disease, Parkinsonian syndromes, multiple sclerosis, or stroke. Very recently in Palimundia, we have a collaboration with the neurology department where we admit patients with stroke. There is a criteria for admission. Not all the stroke patients get admitted. Some of them get admitted in the inpatient unit. Some of them get referred to the home care unit. This study is basically done to understand the effect of integration of palliative care in patients with stroke. So it's just started, but I think there will be a lot of interesting learning from that also. We are also learning a lot because how to manage with all these medications, how to prepare them, how to talk to them about the prognosis, because most of them will be having high hopes that the patient is going to walk again. And some of them may walk, we don't know. So that's something that we are also learning. And symptom control in neurodegenerative diseases, constipation is very commonly seen in many of these patients. And sometimes there is the nervous system disorder like neurobulbar effect. They laugh, they cry, they sometimes become so angry without being able to control the emotion. That is emotional dysregulation, emotional liability, everything happens. That is very difficult to withstand for a caregiver. So these are some of the medications that is recommended for symptom control. Dyspnea, we use opioids in many of these conditions. And sometimes when there is a dyspnea related anxiety, you can use benzodiazepines, psychostimulants for fatigue, muscle cramps, quinidine. I've not used that for muscle cramps. We usually use baclofen. And pain and other symptoms. So I'm not reading one by one. You will be getting this PPT. And these are other symptoms like pseudo hypersalivation, where you can use your TCAs or buscopan to reduce the secretions. there can be agitation. Agitation is very commonly seen in many neurodegenerative diseases. We either use quetiapine or sometimes haloperidol for controlling the symptoms of agitation. And there can be respiratory failure and rigidities. Sleep is another thing that we very commonly see. In our situation, we use quetiapine or mirtazapine for sleep. And if possible, train the caregiver to do physiotherapy at home. And lot of secretions, especially when they are unable to cough it out, then we have to teach the caregivers how to change the position, how to give the chest physio, how to give nebulization. Everything has to be taught to the caregiver. And another major problem that we actually face, we cannot write frailty in terms of, so we have a column to write diagnosis where we used to write old age. Then actually once Dr. Rajgopal says like, is old age a diagnosis? Not really, but they come up with a lot of needs. They need a lot of physical, emotional, and social support. So frailty is another, we do get a lot of geriatric patients reference because when they reduce their functioning in terms of physical functioning, emotional and social functioning, and in our country now we know that the children are not near them. They don't want a home nurse to be taken care of. So these are the situations that we face in our day-to-day practice. So another question: what percent of population, world's population, is projected to be over 65 in 2050? Yeah, 18 D, yes. So I think my answer was 16. And I think in India, I think it will be much worse. In 2050, it's predicted that 16% of world population will be over 65. Compared to 1950, it was 5%. And we know that it's like a chronic illness itself. Like there will be decrease in daily activities of daily living. There will be social withdrawal, cognitive changes, fatigue, loss of energy, physical disability, and increased vulnerability to adverse outcomes, which we actually saw during COVID. How vulnerable they were, and many of them deteriorated really bad during COVID times. And what are the implications? Increased risk of falls, multiple hospitalization, and disabilities. We know, and there is a statistics. I can't recollect from where did I get that number, but 3 to 5% of deaths in older adults could be delayed if the frailty was prevented. So primary prevention is to address the comorbid illness such as hypertension. And many a times what happens, as I said, in neurodegenerative illnesses, the medication itself can cause a lot of issues. Some of the medications can cause postal hypotension and they end up in having a fall. And a comprehensive approach is not being provided at many places. So very recently there was a 90, so this was a personal consult which I went for, a 90 plus. He was already debilitated. He was already disabled because of his polio. He was unable to walk. So he used to drag his body. He used to sit down on the floor and go to the toilet and everything. He had a fracture, which they diagnosed pretty late. But then when they understood that there is something wrong, some deformity, they took him to the orthopedician and they actually put a cast or plaster to immobilize. So he ended up in having more trouble because then he was unable to go to the toilet because he couldn't drag himself to the toilet. And this itself was causing a lot of pain. So sometimes we don't think about who is going through the illness. They just looked at the bone and treated. That's the patient ended up in having more trouble than before getting treated initially. So they wanted that cast to be out. It was not doing any good for him. So primary prevention is to address the comorbidities such as hypertension, and secondary, then we have to exercise and nutrition and management of chronic illnesses. Tertiary, once they reach the advanced stages, then maintaining and improving the function. There can be a lot of symptoms. Pain is very common in many of these patients when they reach old age. And very importantly, maintaining the psychosocial well-being and prevent hospital admission. This is another place where we could talk about the advanced care planning. People are actually willing to hear about it. So very recently, I talked to a group of 60 people who are all 70 plus. They requested to have a conversation on death, like what all will happen when someone is going to die, what all they should be prepared. So I was amazed because I didn't think that there is a lot of acceptance for talk about death, but they wanted to know how death happens in various illnesses, how they should be prepared to avoid hospital admission. So people are willing to talk about it. It's from our side that we should start using those terms of death and dying without any hesitation, I think. Major psychiatric. So this is another question. The prevalence of major depression in oncology. Any guess? How many of them end up in having major depression in oncology? Yes, I can see a lot of B. Yes, that's the right answer. 38% of patients will have. How do you people remember these numbers? I cannot remember this percentage, and many of you are correctly telling the numbers very quickly also. So I'm amazed at that. So this is 38% in patients with cancer. And we know that there is, it can be due to the direct effect of physiological conditions such as hypothyroidism or presence of cancer-induced cytokines or effects of steroids. Many of them will be undergoing treatment with steroids for a longer period of time, and many of the chemotherapy agents. That can be a reason, or it can be a genetic reason also. So what are the consequences of depression in cancer? What happens? We know that, I don't need to read all of this, but we know that there is higher chance that they don't go for treatment properly because they are depressed. They may not be even be able to take care of their own daily activities. So they may not be able to go and get the treatment, and they will have decreased motivation. Like, why should I go to all this? And side effects are seen more commonly in patients with depression. So we know that all these are commonly linked with patients with depression and cancer. And we know that these are the scales. Many of you might be already using all this. PHQ-9 is one thing that we commonly use, or simply asking the distress thermometer, like, are you depressed? That's the, or single question, are you depressed? That's best. In the West, they use that a lot. In our country, that may be slightly difficult. People may not actually recognize themselves having depression. So that question may be a little tricky in our setting. I'm not going into details of pharmacological treatment, but in our setting, we start with citalopram, and once you feel that it is a complicated illness or just something that you cannot manage, then we ask our psychiatrist to come and see the patient. But as a palliative care physician, we restrict our treatment for depression with escitalopram, and then we consult our psychiatrist over the phone or in person. Yeah. So what are the barriers? So we know that these are the burden. We know that all these patients need palliative care, but why we don't get referrals, or we ourselves don't refer patients for palliative care? Any comments on that? Why we don't get enough referrals of non-cancer patients, or why don't we refer if we are on the referring side? Or if you refer, what is your experience with that? Yeah, So there are, accessibility, lack of facility. Yeah, I agree to the lack of knowledge part, Dr. Umesh. I think lack of facility and accessibility, like as we were discussing, um, all of us can do this, right? All of us can manage pain. All of us can manage communication. All of us can give caregiver support. You don't need a specific specialist to treat all these symptoms. This should be done by every physician, every doctor, ideally. Yes, Dr. Prakar is telling physicians wish to treat these diseases. They feel diseases are curable. Very, very true. There is a natural tendency not to send because they feel that. So many times they feel that when someone dies, it's a medical failure, right? Many of us feel that when someone dies, we think that it's our failure. We did not do enough. How can it? No one is immortal, right? Some way or the other, they are going to die. Are we doing the right thing? Are we providing them a good death? A dignified death is something that we need to think. Lack of awareness and stigma, yes. Once you refer the patients to palliative care, stigma is there on the physician's side. How can I refer my patients to palliative care? They think that they are going to die. Or the moment you refer, some patients will ask you, doctor, am I going to die? Why are you referring me to? That is for cancer patients who are dying. Why are you referring me there? So these are the common challenges that I have heard from people. And especially we talked about COPD or ILD. They don't know how long the patient is going to live, right? There is an uncertainty when it comes to non-communicable disease. So they don't know when to start that conversation. So they don't refer. And lack of knowledge that there is a role for symptom management or palliative care in these kind of illnesses also. And someone rightly told a natural desire to be optimistic and to avoid the patients alarming unnecessarily, because they think that when you refer to palliative care, then I am alarming the patient, telling that you're going to die. So they don't want to do that. And as I said, once someone dies, many of the doctors have shared the same thought that when someone dies, it's a medical failure. And many of us are not trained to take care of just the symptoms. We tend to go back to the disease and diagnosis part again and again and again, right? We cannot focus many times on managing the symptom when the disease is irreversible or in the advanced stage. And yes, sometimes there is lack of resources or facility, as you were mentioning, and hospital policies, another major barrier, right? Many of you might be stuck with the hospital policies, I guess. Even if you want to provide supportive care or manage the symptoms in the hospital may not allow you to admit patients for all these. Like, there is nothing which is curable. So sometimes they may not let you to take care of these issues in a hospital. And lack of access to palliative care services. And for the patient and family, even for very educated patients, I myself saw a doctor. He was a very famous doctor. He was diagnosed with heart failure. He was in the advanced end stage heart failure. He was very, very breathless, unable to lie down, very breathless. And they got a call to Dr. Rajgopal, and he sent me to see this doctor. He was very breathless. I suggested low dose morphine, and he could not speak because of the breathlessness. And we were writing and communicating in a book. So I asked questions, shall I start morphine? Then he told, I introduced myself that I come from palliative care and Pallium India. The first response I received from him, the answer back was, I do not have cancer. Then I had to explain that it is not just for cancer, it is for anyone who has suffering. But he kept telling me that I do not have cancer. Then I told about morphine. Then he told, okay, I do not have pain. So these are the barriers that we face from the patients and the family side. Even though they are educated and literate, even though they are medical professionals, people still think when you refer to palliative care, I do not have cancer. And
as of they don't, many times you might be communicating that COPD, it is bad prognosis, it is irreversible, the ILD is irreversible, but they fail to recognize it as a terminal illness. As I said, it's easy when you say you have cancer, people think that I'm going to die. But when you say that it is an ILD, you may be breathless and you may die. They may not understand or accept it. They think that it is a breathlessness. I can use inhalers, I can get treated from somewhere. And sometimes they are unprepared to have the transition from the aggressive care to comfort care. They don't know when to translate, get the transition from the, okay, now I'm done, now only comfort care is there. So they don't know, or they are unable to take that decision of those transitions many a times. Sorry. So when to refer to palliative care? When do you think should we refer these patients to palliative care? Any ideas on that? When should I refer a patient with a respiratory illness or cardiac failure? I totally agree. When should right from the diagnosis? Any other question? If you have a patient diagnosed with heart failure or stage 1 or 2 kidney disease, it's the best to have the integration from the diagnosis. So many places. So you will be listening from Dr. Rajam, who works in Bhatia Hospital in Mumbai, who's a pulmonologist working in palliative care. So they integrate palliative care right from the beginning in many of these respiratory illnesses, so that the acceptance is much better. You are not introducing a new team member when things are getting bad. That is why patients don't trust you, right? When I'm pretty bad, my doctor is just leaving me, sending me to someone else. What is happening? So it's important to have that early integration, so they feel that this is a part of the team. This particular doctor is a part of my own team. I know this person. There is no sudden referral to a foreign person, which about whom they have not heard or seen. Suddenly you are referring, though they think that you are washing your hands off from the patient. As early as possible, till from support from palliative care till the last breath. Yeah, mostly I totally agree, Dr. Mrinal. That's the right from the diagnosis is what we advocate for. But usually they are referred when there is nothing more to do. They are literally gasping. We sometimes get patients literally gasping, sending to us in an ambulance. Where do we have this communication? Where do we have the time to tell? And the caregivers are totally unaware of what is happening. They don't even know the patient is dying. Simply refer to palliative care, and they are coming in a gasping stage. So very, very late referral is something that we also face in our setting. Even though we say the Kerala model is the best, this happens very often here. So this is a tool that might be of help. This is for identifying patients with advanced life-limiting conditions who will benefit from palliative approach. So if you happen to talk to your colleagues about the role of palliative care in non-cancer, they may ask you, when should I refer? This is something you can introduce to them. So they say there are 2 or more general indicators for deteriorating health. This is easily available. There are multiple versions for SPICT tool. It's free of, we can use it for free. There is no copyright issue. Just Google the SPICT tool, you will get it. And it is there for all the illnesses: cancer, dementia, neurological, cardiac, kidney, respiratory, and liver illnesses. They say 2 or more general indicators of deteriorating health and any clinical indicator of 1 or more advanced conditions. So if someone asks you, when should I refer? You can always refer to this tool. There are a lot of studies based on the SPICT tool, very interesting studies from many countries, even from India. So if someone is interested to read more, you can just refer to it. So in cardiovascular illness, they say class 3 or 4 heart failure, the referral to palliative care is very important, or severe inoperable peripheral vascular disease. We do get a lot of patients with peripheral vascular disease, inoperable. with gangrene or pre-gangrenous extremities, terrible pain they go through. It is the most difficult pain to control that I have seen. Very, very difficult pain. And it's a very complicated neuropathic and nociceptive pain, ischemic pain. So it may not really respond to opioids really well. So these are the patients who needs referral to palliative care. Liver disease, advanced cirrhosis with one or more complications in the past 1 year. So there are 5 complications written here. One or more complications in the past 1 year, patients with advanced cirrhosis can be referred to palliative care according to the schedule. Kidney disease, they say stage 4 or 5 chronic kidney disease with estimated GFR less than 30 should be referred, and patients who opt for stopping the dialysis. And advanced diabetes unresponsive to treatment with deteriorating kidney failure. So access to palliative care should be based on need rather than diagnosis. I understand that most of you agree to that. It is need-based, it is not based on the diagnosis. And palliative care should be offered to people who are likely to die within the next 12 months. So this is a surprise question. So many times people ask, when do I know that I need to refer this particular patient to palliative care? This is one thing that you can do. Very important question, very simple question. Ask yourself, would I be surprised if this patient died in next 12 months? If you're not surprised, then you know the answer, right? Ask the question to yourself, would I be surprised if this patient died in the next 12 months? That is a surprise question that you can, very simple. You don't need to go through spectral or anything. If you think that the patient is going to die within the next 12 months, probably that is the, at least that time is the time that to. And the conclusion, it is needed for patients with any serious health-related suffering, which can be cancer or non-cancer. And there is, in our country, there are not much research in terms of need assessment for specific conditions, like what is the need when it comes to cardiac failure, what are the needs when it comes to chronic renal failure. There is not enough studies, especially from an Indian perspective. There are many studies in the West, but not much in our country. I think many places in our country also, I'll stop sharing, cater to cancer palliative care. Many of the centers do not cater to patients with non-cancer palliative care. They restrict the services to cancer palliative care. So, but in our experience, we do get, as I said, more than 65% of patients with non-cancer illness. Whatever I have talked now, we get patients from all these, but not really referred by the physicians. They know about palliative care and they come to us for symptom management, but plenty of them. And from my experience, I think the sensitization and talking to your colleagues' work, I remember talking to a pulmonologist 10 years back. So what I did is, like, I invited him to take a session for us, where I introduced palliative care to him. And slowly we started getting referrals. Then he started sending patients. For one patient who had interstitial lung disease, who was having severe breathlessness, unable to, he was very young and they were very poor, from another state, and very young child, and they were unable to manage the crying wife outside. Somehow he thought about the palliative care and he referred to us. We could manage the patient really well. Good end of life care. We supported the family. Then they got that confidence that, okay, these people can do something if we refer. From that confidence, we started getting more patients much earlier. When they diagnosed with ILD, they sent a young lady with breathlessness, and to have that conversation that how ineffective it can be if she opts for the lung transplant. So they started integrating that much earlier. Once you show them the importance of symptom management, I think you gain that confidence from them to send these patients. Initially, I remember our first conversation, he was so shocked to hear that we use morphine for breathlessness. But then the referrals came, kindly consider opioids for breathlessness for this patient. So that changes over time. It will take time, but it's important to have these conversations with your colleagues from other departments.
Thank you so much. I can take up a few questions. I switched off my video because the network was slightly problem. I'll just check the chat. Yeah, I can see the family adoption program. Exactly, that's the place where Dr. Usha, we can teach these MBBS students the importance of integrating palliative care in non-cancer illness. And I think understanding the importance of incorporating the family members also a part of this whole system. And that is exactly what we were also thinking when we heard about the family adoption program, that that's the right place where they understand the concept of suffering, as well as how the patient and as well as the family goes through all these chronic illnesses. I think at least coming generation, that's why we are all here. At least the MBBS students will be sensitized that these are the actual scenario happening around them. They should start talking about all these options especially when it is not curable. There is another option that you can always give rather than just sending them back. There is always an option of symptom control. There is always an option of comfort care that can be offered rather than just sending them back home. And I still just wanted to reinforce that what I don't remember who told that, but it should be integrated by everyone in their practice actually, not just, they don't need a specialist palliative care. Ideally, I always feel, why do we need a specialty called palliative care, right? It should be done by everyone. It can be done by everyone. All these medications, all these approaches, everyone should do it ideally. As the medical stream stop doing it, I think they evolved another specialty called palliative medicine, but otherwise it shouldn't have happened. Everyone should integrate palliative care in their day-to-day practice. And the population is so big, right? When do you expect these MD palliative medicine people to come and cater to millions of population? And look at the volume of NCDs, look at the volume of cancer, or leave away everything, the frailty, the geriatric population, how much of them are coming up in another 10, 20, 30 years. So we really need to start integrating that from the primary healthcare level. If there are no questions, I can take up questions after the presentation also, because I think it's 4 o'clock. We can just listen to the case presentation and then take up the discussion.
Dr. Maya, will you be able to take up the case presentation? Dr. Maya? If she is not available, someone from the participants can read out the case presentation for her.
It will be great if someone can read the presentation. I can take the rest of my voice for 5 minutes then. Anyone can volunteer. Just she'll change the slides. You just have to read for the others. Anyone, please help me out. Okay, Dr. Maya, please.
Dr. Maya, kindly unmute from your end.
Good afternoon, all of you.
Yes, ma'am, please.
Ma'am, I will not be able to share the screen because I am on mobile and
No problem.
I'm
You can just read
outside
it
the
from
house.
the screen. Can you read it from the screen now?
Yeah, I can see.
Okay.
I can read from the screen.
Yeah, please.
So, good afternoon, all. Myself, Dr. Maya. I'm assistant professor in Sarti Hospital in Bhavnagar, Gujarat. So I'm presenting here a case which came to me one month back. It was an accidental case of a whole family. So we were having a husband, wife, and their 3-year-old daughter who met with an RTA. So I will continue with my presentation. I'm taking here the wife, that is female, who was 30 years of age. Diagnosis was RTA with multiple bone fractures. That was clavicle, right acetabulum, lacerated right lower limb injury with compound fracture of tibia and fibula. So she was presenting with complaint of means she was not very much conscious. She was having altered consciousness, very irritable because of pain, and she was complaining of severe body pain all over the body. She was having pain in my head, in my stomach, in my chest, and she was having very severe body pain due to fractures which were more which were more in number, means multiple fractures. History of illness. Patient met with RTA while going on a bike with her husband and 3-year-old daughter. 3 of them came in our emergency uh, for the treatment. Husband was having fracture of only tibia and fibula, so he was directly shifted to emergency OT. And her daughter was also having fracture of femur, so she was also shifted to pediatric OT in emergency. But our patient, which is 30-year-old female, she was having severe blood loss and tachycardia, and BP was not recordable. So we shifted her to ICU for further management, so we can give her blood and uh, take other investigations before taking her to operation or any other further management. So on examination, she was conscious, but she was very irritable. Her pulse was steady, and 50 systolic pressure was noted. Tachypnea, her respiratory rate was 45, and tachycardia, her pulse rate was above 154. We signed the investigation when we took her to the ICU. Her hemoglobin was 5, WBC count was 4,500, platelets were 70,000. Her blood group was B positive, RBS was 50 only, and PTINR was 14.6 and 1.3. Serum electrolytes were 128 for sodium and 3.1 was potassium. Her RFT and LFT were normal. So our her psychosocial aspect was 30-year married female, husband and daughter both also met with an accident, but she was unaware about the fact how husband is working and how her daughter is. She was housewife from Rajasthan, Jaipur, and she met with accident in our Gujarat, this Bhavnagar district, Gujarat. So came to Bhavnagar for a vacation. So no relative were present at the time of admission, no relative live. So as relative live far away and can come only after 25, minimum 20 hours, because we are having only route to Rajasthan connectivity by road only to Bhavnagar. Patient was agitated, furious, in lot of pain, shouting and calling for relatives, her daughter and her husband, saying, "Save my daughter, save my husband." She was very furious. So our main concern was to make her vitally stable, and psychologically also we were trying to calm her down so surgeries can also proceed. And she was having severe pain, so we were trying out which pain relief, because she was not able to have a lateral position or can sit. So we were not able to give her any block or epidural block. and our concern was her distress and her concern about her husband and her daughter, and arrangement of blood and blood product. So in summary, she was 30-year female, met with an accident, RK, with multiple bone fractures, coming with hypovolemic and physiologically and psychologically disturbed and irritable. So for discussion, I want to discuss and ask my fellows and my seniors, how can we manage her vitally and manage her pain, limb salvage approach, because she was having crush injury of lower limb. So it was like it may be we have to carry on for amputation for her left limb, and counseling and assurance for the same. Thank you.
Thank you, Dr. Maya. So we can discuss if you had a palliative care team in your hospital, like all of you, do you want to refer, or would you like to do something from your own side for managing this patient? If so, what would you like to add on to the current approach managing this patient?
Yes, currently, so we try to arrange the blood products and make her stable vitally. And one of our residents for her was with her, so that she can have psychological support, as she was not having relatives nearby. And the in emergency OT also, we haven't told her about her husband and daughter. We thought first operation will take place, and then we will tell her okay, husband is okay and her daughter is okay. So it was midnight. Both the surgeries were successful and they were stable. So in morning we told her her husband is okay, her daughter is okay, but she was not having faith in us. She was saying if they are okay, why they are not with me? I want them to see. She was also vitally stable in 12 hours. So she was, I want to see my daughter, but she was in pediatric side, and that was far from our where she was admitted. So one of our colleague video called to the next resident who was with her daughter. She is fine. You can see her. And in few days, we will put three of you in same court or same room so that you can see her and you can talk to her. And we called her husband also. He gave consent for all the surgeries, and because he was vitally stable. So we called her husband and told him you should assure her, and we had called her family also. They were in the route only. 12 hours were passed, and after 6 to 7 hours, they were with us. So we did this. And for pain, I means we tried because we were having fentanyl in our institute, so we started with fentanyl. And but she was complaining again and again for pain. So we gave her a patch, the buprenorphine patch.
Thank you, Dr. Maya. I'd like to hear from others also. What do you think about this? Like, what all need? Is there anything else that needed to be done? Do you think this? If you had a palliative care department in all of your colleges, would you want to refer, or you think you should manage the symptoms at your level? If so, what all should have been done? Anything else that you want to add? And a very good approach, Dr. Maya, like you could do a video call so the patient is convinced, because everywhere people say everything is all right. So
Yes,
patients tend not to believe it at all, right?
yes,
So, and she could see and then she can believe herself that they are there. That's a very a good approach, that she can be at peace at least.
Thank you.
I'll wait for the comments if there is anything else that should have been done.
Ma'am, for pain, we had applied patches also, but it was not helpful for her. She was
Yeah.
complaining of the pain.
Maybe Dr. Maya, did you try increasing the fentanyl or because definitely buprenorphine is weaker than fentanyl.
Yes. Yes.
Maybe because we need to just consider that maybe a few days of fentanyl, maybe higher dose, because there is no ceiling effect for fentanyl or morphine. So sometimes we may need to go a little bit higher. Uh, But then, yeah, then we can stop it once she starts recovering.
Yes.
So there is another comment from Dr. Mrinal telling that palliative care can take care of the symptoms and counseling, and for fracture and repairing will be done by orthopedic. Yeah, probably like in your if you are in a critical care setting or in a casualty, probably you may not have enough time to have this conversation all the time, right? There will be multiple patients like this coming. So if you already have a team, usually the palliative care team will have a psychologist or a social worker to have this conversation that will help you in terms of saving your time. They can do all these, as you said, you used some of the interns or anyone who will be able to help you. That's a very, very good approach. So there is a question from Dr. Suranjan. If the scenario is different, like someone of the closest ones is lost, then how to communicate, how to approach? That's a very different scenario, Dr. Suranjan. And I think that is where the involvement of other team will come into play. Definitely, we may have to communicate the bad news to the patient. See, I think we have not reached the communication session yet, right? We have 2 more sessions in communication. I think we have not reached that. But yes, that's a very difficult part to communicate. We have seen that a lot in COVID. Your loved one. A communication session is over for this no year.
No, ma'am, no.
Okay, okay. So that we have seen, we have to tell the patient who is already suffering in the ICU, you had to tell the patient that they lost their loved one. So that will be covered, but we have to tell if they want to. We have to ask whether they are ready to receive the news, to ask whether they, so we start with giving us something like a warning shot, just to see whether they are ready to receive the news. You can't just tell it, or you can't just ask whether you want the news. We'll just give a hint so that they will understand, okay, I'm going to receive something not really pleasant. So give that preparation, ask them whether it can be today. They may say, oh, no, I may need time to listen to that. So they wait for that and then communicate. There's a stepwise approach to communicate the bad news that will be covered for sure in the communication session. But yes, then the scenario is very different then, right? She lost one loved one, and then she herself is in pain and other issues. That will need a team approach for sure, to support her as well as the family, because they have to go through this death and this suffering in one member. So that becomes very different, and you will need a palliative care support for sure in that scenario, or at least your team who your own team who have all these members who can have this conversation. I think everyone is telling Dr. Maya, you've done a good job. I think there is nothing more to add to what you've already done. Yeah, that's what I also feel that. So there is a comment from Dr. Vinal. Maybe I could say most of the time, when we talk with the patient and the attendant clearly in their understandable language about the disease, its prognosis, they understand it. Very true. I think it's all mostly about the language. Sometimes we use the simple language. Yesterday, one of my cousin called and told there is a pain in the arm. Suddenly I asked, is there edema? She's like, what? Then okay, is there a swelling there? So it just comes out like that. We think that's the very simple language, but people don't understand that. So it's very important to talk in the language that they understand and tell them to repeat back to you. Okay, tell me, what did you understand? That is how we should check what they have understood. Otherwise, they keep nodding they have understood something else. It's totally different from what you wanted to convey. So it's important to ask them to tell you back, okay, tell me what did you understand from our last conversation. So that's one way of checking whether they got it right. Yeah, so Dr. Mrinal is telling if you communicate in the language they understand, then it helps to remove the confusion, which mostly leads to fear and agitation, resulting in disbelief in the healthcare personnel and treatment. Very, very true. Because many times we communicate, but they don't understand. And we think that we did a good communication. I told everything, still they are not understanding. But when you tell them to tell you back, that's when you realize that they took it completely on in a different way. That is where we should reinforce this conversation. And there are instances where even if you had communicated really well, they'll come the next day and tell that, no, this is not I wanted, or you didn't tell this properly. That may also happen. Every day you may have to repeat the same thing sometimes, especially when it is a very young person with an advanced illness. There is a lot of denial happening in the family, right? So they'll try to cope with the situation with denial. So sometimes they need to hear it again and again to make themselves convinced. Are there any other questions from the topic or from the presentation? I'll be sharing that presentation, which will have all those references and the papers, which if anyone is interested can go through it. Thank you, Dr. Nilkant. We have 2 separate sessions just for communication. So hopefully the rest of it will be covered in that. That's why I skipped that part completely. If there are no other questions, maybe we can wind up today's session. We need a few more. Sreepriya was mentioning that in the WhatsApp group. We may need a few more volunteers from your side for some of the case presentations in the coming days. So please feel free to send in some of. We know that you will be seeing a lot of patients in your setting. So if you can recollect one, and it's just 5 slides, we are not asking for much details, but only when you come up with real scenarios, then we'll be able to discuss and learn more. So it will be good if you can come up with presentations, volunteering from your side. Otherwise, if there are no other questions, we can wind up today's session. And thank you so much, Dr. Maya, for the presentation and sharing the experience with all of us.
Thank you so much.
Thank you all for joining us today. Thank you, Dr. Sreedevi, for walking us through this important topic. Thank you so much. Thank you all. We'll see you on the next session on next day. That is, I think, on communication 1. Bye until then.